Hello, my name is Ioana Stănescu and I'm gonna start my presentation with rehabilitation and outcome in COVID-induced central nervous system injuries. A SARS-CoV-2 infection is now considered a multisystem disease. Many patients with mild forms of COVID-19 infections report spontaneously neurologic symptoms which were persistent. The most frequent neurologic symptom described was brain fog, which in fact reflects cognitive dysfunction, and it's very frequent, 80% of the patient. Then headache is very often reported, paresthesias, well-known symptoms like lack of taste and smell, muscle pains, and a very frequent symptom is fatigue. For patients with more severe forms of COVID infections, which require hospitalization, neurologic symptoms were more severe and were reported or detected in the variable percent from 36 to 82% of the patient. Most frequent central nervous system syndromes described were encephalopathies, acute and non-specific, in half of the patient with neurologic problems. Then post-infectious syndromes by immune-mediated mechanism, acute demyelinating encephalopathies and myelopathies, and also acute cerebrovascular diseases, especially ischemic strokes, in 6% of the patients. Neurologic manifestations are directly associated with disease severity, but also with the presence of comorbidities and the pre-existing neurological conditions. Rehabilitation is an essential treatment option for this patient because no specific treatment is available, and it was even postulated that half of the discharged COVID patients will possibly need further rehabilitation and social care. COVID-associated central nervous system lesions are produced mainly by immunologic mechanisms and by vascular changes, as you can see in this slide, in which the direct viral invasion is very rare, but immune-mediated mechanisms could induce encephalopathy and also seizure. It's a very frequent modality of central nervous system damage, as well as the systemic inflammation, which could induce endothelial damage and coagulopathy, which are responsible in producing cerebrovascular events, especially ischemic strokes in COVID patients. There are proofs in magnetic resonance imaging studies that COVID infections induce reduction of the thickness and volume not only in the olfactory and gustatory brain areas, but also in the hippocampus, in the insula, and in the orbitofrontal cortex, all important cortical regions involved in cognitive functions. Fortunately, non-specific encephalopathies and demyelinating lesions have good prognosis spontaneously or after immunotherapy. Acute ischemic strokes in COVID-19 patients, they have a worse functional outcome with higher disability rates reported at discharge. Also, these patients were younger and they have a higher proportion of large vessel occlusions than in non-COVID strokes. The main neurological sequelae in COVID-associated strokes are motor deficits, language troubles, especially dysarthria, sensory impairments, and ataxia, and this sequelae required rehabilitation treatment. Rehabilitation intervention should be addressed mainly to a patient recovering from COVID-19 induced stroke, but also in the short period of recovery after myelitis and encephalopathies. Neurologic rehabilitation always should be performed associated with personalized respiratory rehabilitation, with therapy of physical deconditioning, and all these treatment interventions depend on patient comorbidities. This is the reason why COVID patients required multidisciplinary rehabilitation addressing all complex and interconnected dysfunctions. There are many challenges facing for the rehabilitation team for COVID patients with neurological sequelae. First, they are highly contagious patients, especially in acute phases. The patient could be unstable with frequent desaturation or different cardiovascular symptoms. They have low exercise tolerance and they experience fatigue. Also, there is a limited access to inpatient rehabilitation facilities, and the duration of inpatient programs is shorter than in non-COVID patients. Assessment of patient rehabilitation needs should precede rehabilitation intervention in all patients. Clinical and neurological assessment should be performed in all COVID patients. Evaluation of respiratory function is mandatory. Evaluation of exercise capacity. Many items need to be evaluated, like muscle strength testing, joint range of movements, balance function, aerobic exercise capacity, and physical activity assessment. And we can use well-known and specific designed scales for each item. Then daily living abilities should be assessed. Cognitive assessment is important in the working with patients with neurological sequelae, especially memory, attention, and executive functions. The goals of rehabilitation are to improve pulmonary function, to improve motor deficit and obtain better physical recovery, to offer psychological support to the patient, and finally to restore a good patient quality of life. Rehabilitation intervention should begin with patient education, which is considered a key part in any successful rehabilitation program. The patient should receive information about healthy lifestyle, about how important is respiratory training for its condition. The patient needs to be encouraged in participation in the family and social activities. The patient needs to be educated in how to monitor its blood oxygen saturation during exercises, and also needs to receive information about when to obtain medical advice if some warning signs will appear during exercises, like breathing difficulties, chest pain. Respiratory rehabilitation interventions are mandatory in COVID patients with neurological problems. Endurance training by aerobic exercises with gradually increasing intensity and duration, strength training, breathing training, and sputum training by breathing techniques or equipment assistant are very important to perform. Specific neurologic rehabilitation in COVID patients is focused on motor deficit recovery, usually in an inpatient facility with a multidisciplinary team. Early intervention depend on patient respiratory and hemodynamic status. They include postural changes, bed mobility, sit to stand, and simple bed exercises. Further on, when the patient is capable, Active exercises with upper and lower limbs are performed, muscle strengthening exercises and neuromuscular electrical stimulation, walking and balance exercises. Very important are occupational therapy intervention in training patient in the basic activities of daily living and instrumental activities of daily living, trying to minimize the patient disability and to improve its autonomy. Speech-language therapy is essential for patient recovering from a stroke with swallowing difficulties or patient after intubation. Swallowing exercises and exercises for respiratory strength and coordination are very important. Also, cognitive rehabilitation by task-specific exercises addressing attention and working memories are very important for these patients. Rehabilitation interventions could be delivered in COVID-19 patients either in inpatient facilities for patients with severe neurologic or COVID symptoms, could be delivered in outpatient facilities, or could be delivered at home via telerehabilitation. Home-based rehabilitation could be performed in patients which did not require hospitalization after COVID infection, but also in patients which were discharged from a rehabilitation hospital. Assessment of rehabilitation needs and also treatment could be provided via telerehabilitation. This method could be performed either in real time with a physiotherapist training the patient while the patient is performing exercises, or pre-recorded exercises could be delivered to patients. But in these last possibilities, in-person visits need to be scheduled in order to assess patient progress and to reassess the rehabilitation goals. In conclusion, rehabilitation remains an essential tool in the management of COVID patients and especially of COVID-induced neurologic damage. There is very few evidence of rehabilitation intervention in COVID patients with neurological sequelae because existing recommendations are based on methods which were developed during other viral infections or which were developed in chronic pulmonary diseases or other chronic neurologic diseases. So there is an urgent need for new studies regarding the efficacy of rehabilitation intervention for COVID patients with neurologic sequelae. Thank you for your attention.